It's my pleasure to be here to speak to you about support devices during PCI. Here we go. So I have no disclosures to give you about this talk. So I think that the background to this is that there's a huge growing population of patients that are appropriate for PCI, and complexity is progressively increasing. So as complexity increases and the population that's eligible for PCI increases, there's obviously an increasing need for supporting these complex patients as we do PCI. I think protected PCI encompasses patients with complex CAD, multi-vessel CAD, left main CAD, obviously hemodynamic compromise, and there's patient comorbidities that also factor into this decision. And obviously with ageing population, comorbidities are going up. All of these factors go in to, I think, the need for protected PCI is progressively increasing. Another point I draw your attention to is these appropriateness for revasc criteria. These are patients with 2 and 3 vessel disease, on fairly solid medical therapy. You can see that they're all appropriate for revascularization. So these complex patients are the ones that are predominantly the ones that we should be intervening on. They're appropriate, as opposed to these ones down here, less appropriate. And these are the ones, obviously, you're going to be running into trouble with depressed EF and so on. You're going to be thinking about doing protected PCI or using mechanical support. So I think there's this sort of confluence of factors bringing us around to the need more and more to consider protected PCI in high-risk patients with mechanical support. So at the present time, just to set the background, a lot of this talk does revolve around the Impella, because the Impella at the present time is the only hemodynamic support device that's proven safe, effective, and is approved for patients undergoing elective high-risk PCI. So this is the Impella 2.5, the workhorse Impella CP. We have the Impella CP Smart Assist device. There's been this sort of evolution of these devices over the last few years. This is one of the latest, the Impella CP. It has a reposition feature by measuring pressure in the aorta and in the LV. It can actually tell people more for the CCU when the device is too deep, that it needs to be repositioned. So these devices are constantly evolving, constantly improving, and getting easier to use. And certainly, even in my career, what's necessary to get them hooked up online and running has become progressively easier. Just to show the obvious, does the device work? Well, yes, it does. These are just blood pressure data showing that when you put the device in, systolic pressure, diastolic, and mean arterial pressure significantly improves with this Impella device. So the kind of case we're used to seeing, high-risk PCI, 66-year-old male, 85% stenosis in a vein graft, last patent conduit, low ejection fraction. This is a classic PROTECT 2 patient. We'll come to this study in a moment. And you can see here that this is simulated what would happen if you start intervening on this patient with this single remaining vein graft conduit, particularly if you had any slow flow or other problems. Your pressure progressively goes down. However, with the Impella 2.5 on, you're able to maintain pressure, safely get through the PCI, overcome that period of slow flow, and have a successful outcome. So there is a large amount of data to support protected PCI. First, there was the PROTECT 1 and PROTECT 2 trial. We'll go in depth into PROTECT 2 trial in a minute. The Impella registry, literature reviews, and there's also been some recent studies that bring in total the number of patients that we can consider, almost up to 2,500 that have had Impella. So the body of data is growing, and this talk actually from year to year as I give it is constantly evolving. So let's get to protected PCI with the Impella and go through the PROTECT 2 trial. This is a really important trial. I think there's going to be some questions in some way phrased around this study. Published in Circulation back in 2012, and it still remains to the present day one of the pivotal studies that informs us on the use of Impella during the high-risk PCI. So what was it? It was a randomized study, patients having high-risk PCI, and I'll go over the definitions of that in a moment. Basically, they were randomized 2-to-1 to balloon pump with PCI versus Impella 2.5 with PCI, and the primary endpoint was 30-day composite of major adverse events. And these comprise death, MI, stroke, repeat revasc, operations, or other acute complications. The patient population is very relevant. They were patients with unprotected left main or last patent conduit with an EF less than 35, or 3 vessel disease and EF less than 30. So this is why commonly this cut point of 30 to 35, comes into the use in the selection algorithm of the impeller, although as I'll come to later, that's going away slowly. And to just look at the characteristics of these patients, this is like for comparison point purposes, the syntax cohort compared to the impeller 2 cohort. You can see here ejection fraction less than 35, they all at less than 35 in Protect 2 as you'd expect. Heart failure in the overwhelming majority, a lot of unstable angina, diabetes, prior MI, prior PCI, etc. These were truly a high-risk population of patients. Procedural characteristics did differ between balloon pump and impeller, and this is important to consider as we think about the data. Heparin use differed, 2B3A use differed, contrast use differed, and sort of importantly and almost famously now, the use of rotational atherectomy differed. Primarily there was an increased use of rotor with the impeller device. So it wasn't actually a part of the study design, but what ended up happening is that people that got patients randomised into impeller were basically a bit braver with the use of their burr. There was not more use of the rotor, and when the people did use rotor, they also did more passes with the rotational atherectomy device, primarily because probably the blood pressure was better supported, so they felt more comfortable doing that. So there was a difference in rotor use, which was a confounding factor in teasing out the results of the study. You can see also that balloon pump people were supported for a lot longer, for 8 hours after the PCI, whereas the impeller group tended to have it removed on the table. So certainly, in terms of hemodynamic support, the impeller fulfilled its task. This is cardiac power output, or the drop in cardiac output. You can see significant difference with the impeller having a far less reduction or reduced reduction in the power output during the time of PCI. And so to the primary endpoint of the study, it was 30-day major adverse cardiac events, and you can see here that at 30 days the p-value is 0.092. So the study actually missed its pre-specified primary endpoint. And that's an important point. They could easily trick you up on that. Despite that, and for reasons which we could talk about all day, but I think in the end nobody really truly understands, although at 30 days the trial missed its primary endpoint, the same endpoint, major adverse events, at 90 days actually became statistically significant. And there was a 22% reduction, p equals 0.023. And although we didn't really understand why this difference between the 30 and the 90-day endpoint times, this nevertheless was what really gave the impeller device its approval rating and went on to lead the FDA to approve it. And you can see here the diverging curves out to 90 days. So they continued to diverge after the 30-day cut point. Why these curves continue to diverge, I really don't have a great sense on that, although we could speculate about it all day. Just to show you pre-specified sub-analysis, these really were no indications that were clear, although there was a borderline use to rotational atherectomy that was different between the groups, but otherwise there weren't any major significant differences, and we'll come to this again in a moment. Additional safety endpoints, balloon pump versus impeller, there were none. This is of relevance because the French size is almost double with impeller. For a balloon pump, you know, it's around 7, 8. For impeller, it's 13, 14, depending on which one you're using. But despite that, there was no difference in vascular complications. Definitely the impeller devices, and the slides I'll show you now, sometimes they're registry slides, sometimes they're drifting back into Protect 2. But definitely the impeller has enabled more complete revascularization and rotational atherectomy. You can see here there was a higher number of passes with the impeller, more time spent per lesion, and more rotor of the left main when patients were randomized to receive the impeller. This is a sub-study that I actually wrote up with Dr. Sharma and our team on the 3-vessel subgroup in the Protect 2 study, and this is a pre-specified secondary analysis where we just looked at those patients with 3-vessel disease, a reduced ejection fraction. You can see that the same outcomes, broad outcomes that were seen in the main study, were upheld in this 3-vessel subgroup, which failed to make its 30-day major adverse event outcome, but actually again made the 90-day time point. Again, does it maintain hemodynamics? An interesting sort of slow evolution of how we're thinking about this device. You can see here now we're starting to look at the number of vessels treated, and can the impeller help us do more complete revascularization? certainly when you treat 1 versus 2 versus 3, you can see in the grey bars here, there's a more dramatic reduction in arterial pressure as you get further and further into the PCI. However, the impeller seems to protect from this decrease in arterial pressure, sustains your hemodynamics, and allows you to go on to complete these more extensive and more complete revascularizations. And I'll show you in a moment, more complete revascularization is associated with improved outcomes. Good, so other outcomes, and I won't belabor this too much longer, but if you extend from the major adverse cardiac events to look at major adverse cardiac and cerebrovascular events, again, there was a reduction in the 90-day outpoint of Mackie. More complete revascularization, I think this is a very interesting sub-study from PROTECT-2. If there was only one vessel treated, the Mackie outcome at 90 days was not significant. However, 2 or 3 vessels treated, it was an even more dramatic reduction in Mackie than in the whole cohort, suggesting that the people that really benefit the most from Impeller are those in which you're embarking on multi-vessel revascularization and more complex revascularization. Similar rates of outcomes were seen in patients older versus less than 80 years old. Basically, this slide is intended to suggest to you that even if the patient's older than 80, if the vessels are good, it shouldn't put you off using the impeller. In fact, that may be something to motivate you to use it. And if you look at independent predictors of favourable outcomes at 90 days in the study, the use of the impeller was actually one of the independent predictors of a favourable outcome. Also shown to be cost effective, reducing length of stay and repeat hospital admissions. There's interestingly some data coming out largely from registries to suggest that one of the reasons the trial may have actually favoured impeller at the 90-day rather than the 30-day endpoint is because there's improvement in ejection fraction. This is coming both from registry studies, PROTECT-1 and the PROTECT-2 studies. To be honest, I don't really understand why using an impeller would lead to further improvement in EF, months later. Maybe it's less acute damage to the LV that allows it to better recover. But nevertheless, this is a consistent trend across the literature that the use of the impeller may actually favour better recovery of the LV over time. And this is not from PROTECT-2, this is registry data from Louisville, but also suggesting that the use of impeller may help preserve renal function or in fact reduce the incidence of acute kidney injury. So to summarise PROTECT-2, I think it's a critical study for the board purposes and also for your practice that candidates for impeller based on PROTECT-2 are those that are hemodynamically stable, high-risk patients that have depressed ejection fraction, complex CAD and comorbidities. High-risk patients that are appropriate for revasc need to be appropriate for revasc under the guideline criteria, and the impeller is the only device that's approved for use in these patients. Benefits of protected PCI may include the ability to do more complete revasc, including with rota, reduced symptoms and class heart failure, improvement in EF after the procedure, reduced hospital stay, reduced readmissions. So what are the indications for use? And this is an evolution in the device. It's actually changed in the last year or so, so I want to draw your attention to this. The initial labelling for the Impeller 2.5 was basically, as we've said, a system for temporary less than 6-hour support during high-risk PCI in patients that are elective or urgent but fairly stable hemodynamically with severe coronary artery disease and depressed ejection fraction when a heart team discussion has taken place. This study came out in 2018, which actually specifically looked at the use of impeller in high-risk PCI in patients with relatively preserved ejection fraction or EF over 35%. An interesting study that was done retrospectively, but what this study showed is that patients with EF below 35 or above 35 actually had very similar outcomes when they received support with impeller. And this was despite the fact that the patients with EF greater than 35% in this registry actually had more comorbidities, including that they were older, had more diseased vessels, had more multi-vessel PCI, and they also had more use of rotational atherectomy. So this study, although it was a registry study, this study has actually led to a change in the indications for the use of impeller. And currently the indications for the use of impeller has expanded to the 2.5 and the impeller CP. they are still indicated for the same things, but depressed ejection fraction has gone out. So we can now use this device per indications on patients with any EF if it's considered to be high risk for other features, as we've just gone over, particularly complex and extensive disease when planning for multi-vessel intervention. So that's a definite evolution. I think that's definitely something you need to be cognizant of. And indeed, we saw a discussion about this through the symposium the last couple of days. A few things to be aware of in terms of contraindications: thrombus in the LV, mechanical aortic valve or other device, severe aortic stenosis or calcification. There's obviously people that will do balloon aortic valvuloplasty and then use the impeller, but that's totally off-label. Moderate to severe AI and severe peripheral vascular disease that would make the insertion of the device challenging. Additionally, there's a whole bunch of other small print risks that are less important than these critical 5 that I've drawn out for you here. Interesting I'm just going to sidestep for 2 slides here. I think it's important as we consider the use of these devices in high-risk PCI, and we're sort of moving towards this concept of more complete revascularization, to look at the data for complete versus incomplete revasc. And I think the data is becoming fairly convincing that complete revasc is associated with improved mortality, MI, and repeat revasc across broad populations of pooled PCI studies. And if you also look at ejection fraction, with most complete revasc, there is certainly tendencies towards improved ejection fraction. So I think these data showing that you get better outcomes with more complete revasc, plus the data from the impeller showing that the impeller can better support multi-vessel revasc, is a sort of confluence of ideas that enables us to use the impeller in these complex patients to achieve more complete revascularization. Some quick notes for you on these different devices, what the French sizes are. The 2.5 gives a max flow rate of 2.5 or maybe a little bit less. 13 French. The CP is 14 French. There are the 5 and other devices for RV support. Surgery is needed for the 5, but these are really the 2 workhorses for us, the 2.5, the CP, and there's also the CP now with the Smart Assist that gives you these indications of when your position is wrong. Some meta-analysis data looking at the effectiveness and safety of the impeller versus balloon pump. This is a Medline search. Basically, they looked at a total of 20 studies using impeller for high-risk PCI, 4 randomized trials, a lot of observational registry uncontrolled data, 1,287 patients, follow-up out to 3.5 years. Impeller resulted in improved procedural and hemodynamic characteristics. In controlled studies, 30-day rates of all-cause mortality and MACE were similar across groups. And the conclusion of this, supporting the PROTECT-2's trial data, is that the impeller device improves procedural and hemodynamic parameters. There's limited data, larger trials are needed, but nevertheless it definitely supports the use of this device for these indications. Let's move away from the impeller and talk about tandem heart. This is a more complex device. I think it's important to spend a few slides on it just to touch on it and consider when, if ever, the tandem heart may be your device of choice. Again, this is a totally percutaneous but extracorporeal platform for temporary circulatory support. It can provide significantly more support. The impeller 2.5 is 2.5 litres, the CP is about 4. This does 5 litres of percutaneous support, capable of full pressure support. It withdraws oxygenated blood from the left atrium, so you need to do a transeptal puncture to get into the left atrium for this, so the complexity of insertion is high with the need for that transeptal puncture. And it provides up to 5 litres of forward flow with blood returned to a major central artery. So we compared the impeller 2.5 versus tandem heart from our registry data a number of years ago. I was the first author on this paper. And what did we find? 68 patients, about half had impeller, half had tandem heart, undergoing high-risk PCI, 71 years old, a lot of diabetics, ejection fraction 31%, in many diseased vessels. These were truly a high-risk population of patients undergoing complex PCI. A lot of the patients had LAD, complex lesions, including vein grafts, high use of rota. You can see our rota use was almost a third of these patients, or actually 44%. And you can see here in terms of outcomes, no difference whatsoever in terms of death, MI, stroke, urgent CABG, anything else. No difference in the outcomes for this supported PCI with impeller versus the tandem heart. Here you can see events-free survival, survival to death, MI, or death MI, or TLR. No difference between these devices. And you can think about this. If they both do a good job in supporting the patient, why should there be a difference in outcomes? We were thinking the impeller might be quicker and easier with its less vascular complications. That wasn't the case in this smaller cohort. So the conclusions from this study is that both impeller and tandem heart are feasible, safe and effective during high-risk PCI with no difference in acute or intermediate complications or outcomes. However, the tandem heart's obviously a lot more complex to insert with the need for 2 catheters, very large, 20 French, and need to cross the intra-atrial septum. So when would you even consider using the tandem heart given this complexity? One is for LV thrombus, because the tandem heart has the great advantage that you don't have anything in the left ventricle. It's only the right atrium and a central artery. Significant native aortic valve disease is another. Metallic aortic valve prosthesis, you don't want to cross it, or you can't put this big bulky device across it, is another indication. People have spoken about using the tandem for support during TAVR. I think there's a few case reports, but no one's obviously systematically using it for this purpose. Or severe aortic pathology, when you've got severe atheromatous disease and you're worried about stroke. You still need to put a fairly large bore catheter in through the femoral up into the iliac. So you still don't avoid the need to transgress the iliac artery. So for that purpose, PVD isn't necessarily something that favours one device over the other. There are some hemodynamic features to consider, and I'll bring in ECMO here. The tandem heart is designed to augment flow, but also reduce cardiac work, and I'll show you how this works. If you look at flow volume loops, and I'm sure this is stirring a few brain cells for a lot of us, if you look at these flow volume loops, you can see what the tandem heart does, because it actually removes blood from the left atrium and returns essentially, it actually decreases LV volumes with actually some decrease in LV pressure. The impeller doesn't have such a dramatic effect on decreasing LV volumes, and ECMO actually does nothing to decrease LV volumes because you're draining from a central vein and returning to a central artery. So these hemodynamic considerations I think are very important, because what the key thing is if you need to decant the left ventricle, if you need to get the LV EDP down, the tandem heart is actually the most effective. The impeller is intermediary, and ECMO is actually the worst. So depending on your hemodynamic situation, I think this is very important to consider. I think ECMO has become a go-to device for crashing patients in the cath lab. I wouldn't ever discount it for that role. But very worth considering that ECMO, it doesn't decant the LV. If anything, it loads the LV because you're returning to a large central artery and draining from a vein. So just to summarise these devices, tandem heart provides physiologic pressure and flow. It gives maximal LV unloading, as we've just said, up to 80–90% unloading. Far more complex insertion requiring a transeptal puncture. The impeller device, comparable flow to the tandem, only with the very large devices that require surgical implantation. It can't crank up the pressure quite as effectively as a tandem, but it's certainly the easiest of all the devices to use. And ECMO, others, physiologic pressure and flow, but there's a significant increase, particularly in left ventricular pressure, volume and strain. So in contemporary practices, the tandem heart, I think complex PCI, when an axial device is contraindicated for those things we've said, acute cardiac failure, perhaps right heart failure, although the right-sided impeller is earning a spot in that market, and for surgical support. I want to talk about the SHOCK 2 trial and change gears again and get into SHOCK 2. This is another pivotal study that informed our clinical practice, dramatically changed our clinical practice, and really turned us off the routine use of the balloon pump in patients with cardiogenic shock coming in with acute myocardial infarction. The study was published, this is the planning, it was published in 2012. They got 600 patients and randomised them to balloon pump, 300 in that arm, or control with no balloon pump, the second arm. Paper was published in New England in 2012, 7 years ago, and the key takeaway message from this paper is that the use of balloon pump did not reduce 30-day mortality in patients with cardiogenic shock complicating AMI who went to the cath lab. You can see the characteristics of the patients here. They really were truly patients in cardiogenic shock. You can see here altered mental status was in 70%, quite remarkable. Cold, clammy skin, oliguric, and so on and so forth. Lactate, I think, was high, and so on. Truly a population in florid cardiogenic shock. And despite this fact, the quite famous curves for this trial show that there was no difference whatsoever for the control patients versus the balloon pump patients. By subgroup, again, no important differences were noted, suggesting that there's no subgroup that might differ. The outcomes were extended out to 12 months, and again, exactly the same findings with no difference in the curves whatsoever. So the IABP2 shock trial failed to show any benefit of balloon pump use in patients with AMI complicated by cardiogenic shock undergoing PCI. This really did impact practice, and I think it still impacts your practice today, that if patients are in cardiogenic shock, you should think twice before putting a balloon pump or a support device in. We still do it a lot reflexively because it makes us feel good, but the data doesn't necessarily support that. So just to finish up on some guidelines for you, what is the most current? The most current stuff from the US is actually at least 5 years or more out of date. But the 2013 ACC AHA guidelines for the management of STEMI give balloon pump a class 2A recommendation, basically saying it can be useful for patients with cardiogenic shock after STEMI who do not quickly stabilise. So that gives you a window to try to stabilise them after the PCI, and if they don't stabilise it, you can consider it with a 2B recommendation. A 2A recommendation, sorry. 2B recommendation was given to alternative devices, and they're really hinting at the impeller here for circulatory support because the impeller hasn't been rigorously tested in a randomised controlled trial in patients with acute AMI and shock. But nevertheless, it's a 2B indication. The European guidelines, I doubt this will be asked of you, but just to give you some context, the 2017 European guidelines are far more recent and give very similar recommendations. A 2A recommendation for intra-aortic balloon pump in patients with hemodynamic instability or cardiogenic shock due to mechanical complications. So here now we've actually progressed to patients having complications. So routine shock, not discussed. Short-term shock may be considered in patients with refractory shock, a 2B, and routine use of a balloon pump gets a class 3 recommendation. So you shouldn't do it routinely in patients in cardiogenic shock. Non-STEMI guidelines are similar sorts of things. Balloon pump can be considered in patients with severe, persistent or recurrent ischemia if they're awaiting angiography or revac despite intensive medical therapies. And here saying it failed to reduce MACE. So selective use in patients that are not doing well. So I'll end there. I'm happy to take any questions. I wish you all the best in your exams, and I hope this has provided some useful context and background to some of these important studies. Thank you.